Hi, my name is Lusana Schutz. I'm an emergency medicine physician and clinical instructor in the Stanford University Hospital Emergency Department, and I'm here to present a case on seizures. So we will get started. This case is a 25-year-old man brought in by family with complaint of unresponsiveness and jerking movement of his body, which started about 10 minutes prior to arrival. As we do with all our emergency medicine patients, we approach them with this emergency medicine approach by evaluating, thinking, and acting. This may occur sequentially or all at the same time in the critically ill patient. For our patient, in our initial assessment, we see in the general appearance and level of consciousness that he's unresponsive. He has tonic-clonic movements of all the extremities. When we assess his airway, it appears that his tongue is in the back of his mouth, partially obstructing his airway and causing snoring breath sounds. His breathing reveals a rapid, shallow breathing pattern. And when we assess his circulation, he has rapid, strong pulses, but he feels warm to the touch. While we are doing our initial assessment, our dutiful nurse has gotten vital signs for us and shows us that he has a heart rate of 125 beats per minute, a respiratory rate of 32 respirations per minute. His blood pressure is in an acceptable range of 136/87, but his oxygen saturation is low at 89% on room air, and his temperature is 36.9 degrees Celsius. What test do you want to do immediately while you're getting vital signs, if possible? That's blood glucose. And this is because hypoglycemia is a life-threatening illness and is easily treatable and reversible. So in our initial assessment, we see that our patient is unresponsive with tonic-clonic activity. He has abnormal vital signs including tachycardia, tachypnea, and hypoxia, and his glucose is about 160, which is slightly elevated, but okay for right now. What are we thinking about this patient though? Is this patient sick or not sick? I hope you're all saying that yes, this patient is very sick and needs to be needs intervention immediately. So again, you should also be thinking this patient is having seizure activity and thinking seizure is a life-threatening emergency and requires immediate action. Again, take caution that seizures may present atypically. This patient is having a fairly typical seizure with tonic-clonic movement in all extremities, but not all patients present this way, and you can't treat a seizure if you don't recognize it. Here are pictures and videos of 3 children having seizure activity. The child in the upper corner has tonic-clonic movement of one arm, so a focal seizure. The patient at the bottom this is just a picture, but I'll tell you that the patient is extended, is tense, and is rigid in extended form along his back. The patient on the right-hand side there has deviation of his eyes to the right and some smacking movement of his lips. So all of these look different, but they are all seizure activity and need to be recognized as seizure activity immediately for prompt treatment. I'm going to present 4 goals of seizure management. This is how you should approach your patient with seizure activity. First, you want to assure assured oxygen delivery, and this is by addressing and treating your airway, breathing, and circulation problems. 2, you want to stop seizure activity as soon as possible. 3, you want to diagnose and treat the underlying cause. And 4, you want to prevent further seizure activity. So first, we're going to talk about assuring oxygen delivery. And again, this is by doing your initial assessment and addressing your airway, breathing, and circulation. So as far as airway, you may need to position the patient if they have vomit or blood in their mouth or secretions. In the emergency department setting, we will use suction to assure that to remove any vomit, secretions, or blood in their mouth. We may place a nasopharyngeal or oropharyngeal airway for breathing. Likely, you should assist all patients that are having seizure activity with supplemental oxygen, and you may need further airway equipment or advanced airway intervention. For circulation, you want to establish an IV as soon as possible and start IV fluids. For our patient, we suction secretions out of the mouth and some blood that's present. We place a nasopharyngeal airway, and we supplement with oxygen. We prepare airway equipment if it is necessary, and we establish IV access and start fluids. Next, we want to stop seizure activity. The longer a seizure is occurring, the harder it is to stop, and the greater the risk of neurologic sequelae, the longer the seizure is ongoing. So it's really important to stop seizures as soon as possible, because this is a cycle that we want to stop as early as possible. What is the first-line agent or medication for seizures? Is it phenytoin? Is it phenobarbital? Is it dextrose, or is it benzodiazepines? And the answer is benzodiazepines. When we think about stopping the seizure activity, during our initial assessment, we're looking for reversible causes that we can readily treat right away, such as hypoxia, hypoglycemia, and fever, particularly in children. But then we also need to go quickly along and treat the seizure if we can't reverse it immediately with one of these interventions. And again, the first-line treatment is benzodiazepines. If the patient is unresponsive to benzodiazepines, or for some reason they're not available, you may treat with phenytoin. Newer anti-epileptic medications such as levetiracetam or Keppra are also an option. Phenobarbital is an option, particularly in children. This would be your third-line agent. And then also, if all of these do not work, your patient continues to have seizures, you may have to induce general anesthesia with an agent such as propofol, or put them in a barbiturate coma. This requires ICU level of care, ongoing hemodynamic monitoring, and should have continuous electroencephalogram to monitor for ongoing seizure activity. Caution, do not miss easily reversible causes of seizure, such as hypoxia or hypoglycemia. These are life-threatening and can be treated readily in your initial assessment if noted. Here are the regular dosing from adults of some of the medications that I mentioned, such as diazepam, lorazepam, midazolam, which are benzodiazepines, phenytoin, and phenobarbital. What if we're unable to get IV access in our patient? Should we delay giving them medication so that we can get an IV? And of course, the answer to that is no, right? Without IV access, you still can and must treat seizures early. Remember, the longer a seizure goes on for, the harder it is to treat, and the more likely the patient will have a bad outcome. So don't forget about other routes of administration. Intramuscular is a rapid and easy route. Also, there are other routes as well, such as per rectum. So midazolam and lorazepam are two commonly used medication that can be given intramuscularly. So we give our patient, luckily we're able to establish IV access, and we give our patient 2 milligrams of IV lorazepam. After a few minutes, we reassess the patient, although we're standing at bedside the whole time, and it seems that the patient seizure activity has stopped. The heart rate has come down a little bit, the respiratory rate has also improved, and the oxygen saturation is up to 95%. His jerking or tonic-clonic movements seem to have stopped, and the patient is sleepy but somewhat arousable with painful stimulus. Caution. Patients treated for seizure need to be watched closely to see that their level of consciousness improves and that they don't develop another seizure. So your seizure patient is a critically ill patient with a life-threatening illness, and you shouldn't leave their bedside until their seizure has stopped and they have stabilized. They require continual reassessment to see if the treatment you're giving is working and to make sure that they return to normal mental status and that they don't develop another seizure. So in summary, for this part of our case, recognize seizure activity. Remember that not all seizures present typically, and you can't treat a seizure unless you recognize it. All patients with seizure activity are sick and unstable and need action immediately. Assure oxygen delivery by addressing your airway, breathing, and circulation. Look for reversible causes of seizure, including glucose. And remember, stop seizures as soon as possible. The longer they go on, the harder they are to stop and the worse outcome for your patient. Thank you for being involved in the first part of this case. We'll see you for the second part.